So in my previous talk, I had told you about the clubfoot deformity, CTV deformity, the primary or the idiopathic one. What are the changes in the, why is it, how is it caused, what are the etiological factors, what are the pathological changes in the bones, muscles, ligaments, tendons, skin, etc. Now today we would be discussing about clinical presentation of the clubfoot. How does it present to you? How should you diagnose it? What are the radiological features and all that? So once we see a clubfoot, we examine the foot total and we find that heel is small and this is an equinus. Equinus means plantar flexion of the ankle joint, as I told you earlier. The whole foot is inverted. There are deep creases on the medial and the posterior aspect of the foot. Here this is the foot. This is lying in plantar flexion, so there is equinus. The foot is inverted. We see deep creases on the medial side of the foot and on the posterior aspect of the foot. There is also, if we try to correct the foot, there is lack of correctability. The degree of which will vary. In the mild clubfoot deformity, you of course would be able to correct it, but in rigid clubfoot, it would be very difficult to correct this deformity. And there are some other joint and neurological abnormalities also we should examine that. So how do we classify clubfoot deformities? Idiopathic and non-idiopathic. We discussed about that idiopathic clubfoot, there is no underlying pathology either in the foot or in the anywhere else, but this deformity presents congenitally, and there are certain theories like mechanical or hormonal theory, intrauterine pressure increases, some hormonal problems or some genetic theory which are responsible for the idiopathic type of clubfoot, or non-idiopathic or secondary clubfoot. We learn about the Cummins classification. So what is Cummins classification? Based on the Cummins classification, classify the clubfoot into supple foot, neglected foot, a relapsed foot, or a recurrent or a resistant clubfoot. So what is a supple clubfoot? This is one where the foot can be brought to normal position and all joints are mobile. A neglected clubfoot is one where the patient has not received any kind of treatment for about 1 year. A relapsed clubfoot is one which once got corrected, but then this clubfoot deformity reappears after the treatment. Recurrent clubfoot is one in which the deformities reappear while still under treatment, while during the treatment. And a resistant clubfoot is one where no correction after conservative management has taken place. So basically this describes the type of the clubfoot that one is treating. Now, based on the severity of the clubfoot deformity, there is a Pirani scoring system. For each deformity, for each presentation, it has got a score, and we add up the score, and that determines the severity of the clubfoot deformity. So this is a very simple and reliable system to determine the severity, and it also has got a prognostic value. When we are treating clubfoot deformity either with surgery or with plaster or with manipulative correction, we repeat Pirani scoring after some time and we come to know whether it is improving or not. So how do we score? There are 6 signs which are assessed in a clubfoot deformity. Of these 6 signs, 3 signs are in the midfoot and 3 signs are in the hindfoot. For each sign, if the sign is severe, with severe abnormality, the score is 1. If it is partially abnormal, it scores 0.5. and if it is normal, then it scores 1. So what are these 6 signs? The scoring system, as I told you, allocates 0, 0.5 and 1 for each of these 6 clinical features. Presence of the medial creases. In the club foot deformity, the foot is curved inside and creases form on the medial border of the foot. So this is one sign, presence of the medial crease. Second is the curved lateral border of the foot. Because the foot is turned inside, of course the lateral, there is lateral curvature of the foot. So we have to look for the severity of this sign also. Then palpability of the lateral head of the talus. As I told you in the etiopathology, the navicular bone subluxates downwards and medially. Therefore, the talar head gets uncovered and it is easily palpable over the dorsomedial part of the foot. So we have to palpate this. And in the hind foot, there are 3 signs. Presence of posterior creases. Because the foot is in equinus, so creases are formed just on the back side of the ankle in the tendo-achilles region. Second, if we put our finger on the calcanean tuberosity, we'll find if in a normal foot the bony hard presence of the calcanean tuberosity, but in clubfoot deformity you will not feel any bony hardness over there. So this is empty heel sign. And thirdly, rigid ankle equinus, in which we try to correct the deformity, but if it is rigid, it cannot correct, then it is a severe sign. Next, we take the radiographic evaluation, where there are certain important angles that we measure. Talocalcaneal angle on AP and the lateral view. Tibiocalcaneal angle on the lateral view, and talus first metatarsal angle. So here is the AP radiograph, where we see the talocalcaneal angle, and normally it is 20 to 50 degree. However, in CTV this is less than 20 degree. So first line is drawn through the center of the long axis of the talus, and second line through the long axis of the calcaneum. For the we'll go to the next. On the lateral view, there is decreased talocalcaneal angle, and there is disrupted talar first metatarsal angle. This is the lateral talocalcaneal angle, which is also called turquoise angle. And in the club foot, the lines have become parallel, and in a corrected foot, it is making an angle of 42 degrees. So measuring these angles will help us make the diagnosis whether there is a club foot or not, and it also has got a prognostic value that these angles are restored to normal. So having discussed this, we'll discuss the treatment or the management of the club foot in my next